Today we are showing a very severely calcified vessel PCA, and this patient had unstable angina, classical episodes of chest pain, and a severe triple vessel disease, right coronary, non-dominant, CTO, L6 bifurcation lesion, LAD diffuse long segment lesion involving RCM2, mid distally also diffuse, but it's a well patent vessel. But proximal to mid severe calcification that middle lead level patient had a very tough calcium. Initially they tried to cross the lesion in one of the periphery centers, but they were unable to cross. Then they deferred the procedure. Then the patient came to us with a history of uncrossable balloon uncrossable lesion for PCA of LAD. So 80-year-old male. We did the COVID test, COVID antigen negative. He had a fever, so that's the reason COVID antigen was done twice. Both tests were negative with 48 hours gap. Then RT-PCR was performed, that was also negative. CT chest showed mild infiltrates, so he was treated with high-end antibiotics and the infection was controlled. Today we posted him for PCA. Initially we thought we'll do from the right radial, 80-year-old male, because the calcified slightly abnormal location of the ostium of the left main, we were unable to engage with various catheters. We tried Amplage 1 and 2, we tried JL catheter, EBU, XP. So there was no proper alignment. So that's the reason we changed it to femoral approach. Then this is a femoral. So we have put the balloon tipped pacemaker because left circumflex is bifurcation lesion, LAD diffuse lesion, balloon uncrossed lesion, and right coronary CTO. Because that we thought of if no flow, slow flow develops, the patient chance of developing complete heart block very high. Then here also we tried with the various catheters. We were having a difficulty, but ultimately we could enter with a JL catheter, and after placing the JL catheter deeply into the left main, go to the next. You see this is a JL catheter. With the micro catheter support, then we crossed the lesion with BMW wire. So this is the placement of BMW wire. So this is the image. Once we have crossed the lesion with a micro catheter, it's very critical. There is no flow distal to the lesion. So total cutoff of middle LAD level, middle LAD lesion. Then immediately we thought we'll exchange with, because in another center they tried with balloon, but they were unable to cross. Then immediately we changed it to this is the rotafloppy wire. We are exchanging rotafloppy wire using microcatheter. Balloon traffic technique was used. Then go. You can see subsequently we did the rota. The rota we passed in left main. We gave almost 12 runs of rota ablation using 1,60,000 revolutions per minute, 1.5 bar, rotafloppy wire. So you see, even every run it was there is a significant drop, that is almost 9 to 10,000 revolutions. Then we were giving a small, like a 10 seconds rotablations, multiple. Then finally we could cross that tough lesion. Then you can see the injection. Now it's flowing well, antigrade flow is good. So final polish runs were done. You can see very clearly. Now we have crossed the lesion. After that, then we exchange the rotafloppy with again distal we place a microcatheter. Our intention is to change with BMW wire, but patient suddenly developed VTVF. So suddenly after giving NTG and nicorandil, then patient suddenly developed VTVF. So then we carried CPR, multiple DC shots were given, and we started noradrenaline. There was no recordable pressure. Noradrenaline was given, dopamine infusions were started and intubated. So after 5 minutes of CPR, then during CPR only we put the BMW using the microcatheter, then balloon trapping, remove the microcatheter. Then subsequently we took the 2 mm balloon. The lesion was dilated with the 2 mm balloon, but it was like a, because watermelon said effect, it was slipping, like a we were unable to achieve adequate dilatation with you see it's slipping, so we were unable to achieve any balloon dilatation with the 2 mm balloon. Go to the next. Then we took the 3 into 15 mm. This is the open NC balloon. So our intention is to adequately, because it's a tough calcium, rotor, even after rotor, I feel better to adequately modify the plot. Then open NC balloon, entire middle LAD, proximal LAD was dilated. You see there is a tough lesion even after open NC. Pull back. Then you can see up to ostial LAD, then we dilated with open NC balloon. Went up to 40 atmosphere inflations. Even ostial LAD was dilated. And then we placed the Zines expedition 3 into 38 mm based upon the distal vessel diameter. Using the guide liner, we were having a difficulty in placing. Then guide liner, Guidezilla was used. This is 3 into 38 mm expedition and inflated up to 18 atmosphere. So ostium was covered nicely, and then high pressure inflations, almost 2 to 3 inflations were carried out. Then we thought of using the same open NC to dilate the lesion, but we were unable to push the catheter open NC balloon through the Guidezilla. Because the profile is bigger, it's not going through that. Then because of that, then what we thought, we removed the open NC balloon, used the balloon. Because for this patient, already we have used for pre-dilatation new balloon. The same balloon we wanted to use for post-dilatation. Because of the profile change, it was we were unable to cross. Then subsequently, we took 3 into 15 mm NC balloon with high inflations, that is almost 22 atmospheres. Entire LAD stent was dilated. Then you see subsequently we placed 2.75 into 12 mm. Distally there was mild haziness. So because that we placed a stent up to 12 into 2.75 mm balloon stent. That is also Zines expedition. You see now we are placing 2.75 into 12 mm stent, and then pull back the same balloon. We went up to 22 atmosphere, high pressure inflation, and then subsequently this is a post dilatation of the same because the 22 almost we achieved 3 mm diameter, 3 plus diameter. So then we wanted to check the IVAS findings, real stent is expanded well or not. See, now you can see IVAS shows nicely expanded stent. Almost we achieved 3 mm diameter post stent. Everywhere it's like a spherical appearance and nicely expanded. No malapposition, no under expansion, and no edge dissection. You can see the left main. Because we were facing difficulty in engaging left main ostium, we checked the left main ostium. Left main ostium is nicely, the vessel diameter is almost 4.2. So then see calcified, but it's there is no significant stiffness of the left main ostium. It was calcified, and here if you see the left main area is almost 5 mm. See, it's a big vessel, 5 mm diameter. So then final views you can see the L6 bifurcation, because L6 bifurcation is flowing very well. We wanted to stage a procedure for L6 bifurcation because this is itself a very complex procedure. So then LAD is flowing very well. Then you can see very clearly this is the final view. Stent is very well patent and distal LAD is flowing well. supplying subtles and diagonals, and there is almost immediate 3 flow. So this is the case we wanted to share. Our intention is to show very complex PCI, uncrossable lesion, how to manage effectively. These patients are prone for low flow, no flow during procedure, anticipate development of complete heart block. Sometimes they may develop VTVF because the slow flow, no flow. Then during that time, you have to be, you should have a patience and manage very carefully. Many times you will provide the, with the imaging, you can provide the best outcomes. Thank you, Vandal.
Sunshine, it's our sunshine.